çok değerli katılımcılarımız, vaka toplantıları öncesindeki son oturumumuzu açıyoruz. Hepiniz hoş geldiniz. Ben bu fırsatla bu güzel toplantıyı düzenleyen organizasyon komitesinin tüm üyelerine ve özellikle sevgili Oktar Asoğlu'na teşekkürlerimi iletmek istiyorum. Sevgili Sümer'in gecikmesiyle de onunla moderatörlüğü paylaştığımız için de ayrıca onur duyuyorum. Bizi ısındırdılar epey Beck'le göre. Bütün bu stratejinin açık kapılarını tek tek irdelediğimiz bir toplantı süre gidiyor. Bu oturumda hangi hastalar Beck'le gör stratejisiyle takibe uygundur sorusunun yanıtlarını barındıran konuşmalar dinleyeceğiz çok değerli konuşmacılarımızdan. Ben sözü sevgili moderatör arkadaşım Oktar Bey'e bırakıyorum.
Süha Hocam çok teşekkür ederim güzel sözleriniz için. Evet, bu panelin sonunda tartışma başlayacak. Bir sürü olgu var. Hep beraber bu olguları değerlendireceğiz. İlk konuşmacı olarak Sayın Geerard Beets'i kürsüye davet ediyorum. Yanıt değerlendirilmesinde klinik ve veya moleküler belirteçler var mıdır, yararlı mıdır adlı konuşmasını yapmak üzere Sayın Geerard Beets'i kürsüye davet ediyorum. Dr. Beets, please.
Well, thank you again. I'm not a basic scientist, so this is going to be more of a clinician's view on how we can use it. Are they helpful? I could give you the answer already. No, they're not helpful, at least not yet, but I'm sure in the next 10 years or so we will start using it. To get the terminology right, if you start reading papers on response prediction, you should realize some authors mix it up. We call this assessment of response, and prediction is right at the start, before you've given any treatment, to decide, is this patient going to respond very well or not? So for the group of large tumors, where you've already decided on the clinical features that you're going to give chemoradiation anyway, as Rob Glyn-Jones pointed out, some information, if it's not going to work at all, you could try another approach and give them chemotherapy. But for the sake of organ preservation, you don't need prediction model. This group of patients with large tumors, only 10 to 25% will show a complete response. But it is for the smaller tumors. You could go straight for surgery, or you could try organ preservation, so you have the intention to give additional chemoradiotherapy with the goal of organ preservation. And in these patients, and you can add a local excision, you achieve organ preservation in more or less 50% of these smaller tumors. But it is this group of patients that this prediction model can be highly interesting, because these are the trials that show that you have at least 50% of organ preservation. There are a lot of other trials. So these patients are the winners, because they got chemoradiation and they avoided major surgery. But 50% still requires TME surgery, and they have a worse function, because you could have operated on them. You could have done a low anterior resection, maybe an intersphincteric, without radiotherapy, and they will now have a worse function. These are the losers. So do these balance out? So if you only were to predict my patient has a higher chance of becoming a winner, then you could make a more rational choice for chemoradiation in these smaller tumors. So what are the candidate predictive factors? You've heard some of them already. There are a lot of clinical factors about the tumor, but also about the host. some molecular markers, biopsy markers, and we've heard of the imaging radiomics. So I will discuss something about these two. The one that stands out is tumor size and tumor volume. So that is one of the basic laws of radiotherapy. And actually, when all the retrospective studies that showed T stages related, N stages related, even EMVI, they can all be led back to tumor size and volume, because your smaller tumor has a lower T stage, has less N stage, has EMVI. So if you put this in a multivariate analysis, sometimes this comes out, sometimes this drops off, and it's only tumor size. There are some reports that distal tumors do better. There is a report that says they have 1.5 to 2 times more complete responders. In our meta-analysis, it's not 1.5, but yes, they have a little more complete responses. But that could also be just a tumor size effect, because the more distal the tumor, the earlier your symptoms, the smaller the tumor. So that could be size too, rather than something inherently biological. The same for lower CEA level. That is actually related to the volume of the disease. So in all these studies, if you do multivariate analysis, they all have different outcomes, because sometimes these factor each other out because they are related. So the one thing that still stands out is tumor size. The other thing is patients with mucinous components, they do worse. That is something different than tumor size. I think you've seen this already, Rob Jones. So this is our meta-analysis. T1, but there are only very few in here. They have 58% of complete response, T2 tumors 28, T3 16, T4 12. This is probably just volume. So this is the paradox. We give chemorad in these bigger tumors and they have some chance of complete response, but it's these patients with smaller tumors that really have a higher likelihood. This is another study from the MD Anderson, and there you see the type of effect. This is univariate, low CEA level. They put their cutoff at 2.5, so it doubles. If you have a low CEA level, you have twice as high chance of complete response. Sorry for the microphone. But that is probably also just a volume effect. And they had circumferential extent 2, which they divided in 2 and it doubles. This is volume 2. So far the clinical parameters that you can use. Then the biomarkers. There's been a lot of research on biomarkers. I'm not going to name all of them, so I'm sorry if you studied it and you're not mentioned. I apologize. It seems that research labs who have a research line in one of these, they try out what they're trying out in every disease. So there's a lot of different reports on a lot of different factors. You can see them here. I'm not going to read them, but these are all related to tumor biology, and the immune response that's been alluded to is the recent addition. You can group them into different kind of groups. These are the DNA alterations. You can study chromosomal instability, and some groups report that they find something. KRAS mutation, less chance of response. These are more focused DNA investigations. You can spend a lot of money and look at gene polymorphisms, do whole genome analysis, mutations on single nucleotide changes. This is not something for clinical practice, but this generates new possible markers that should then be investigated in a more practical setting. The same holds true for gene expression profiles. You can group together like 100 gene expression types, and you can, with microarray, study them, and something will come out. And then another group does something else, something comes out, and there's just a little overlap. So these are the groups that are studied. So this generates data that should be explored further for something practical. Here's a list. These are the easier studies. You do immunohistochemistry or some other type, and you study just a couple of isolated factors, proteins. For all of these that are listed here, there are reports saying, yes, there is a correlation with response, and no, there is not. So there's nothing very consistent that comes out, but the methodology is very different. So there are a couple that are sort of promising something, and if you're looking for the one biomarker that is going to give you the answer, that is never going to happen. So it always has to be a combination. These are other things that people are trying out too: epigenetic changes, microRNA, circulating protein, and DNA fragments, like was mentioned in the discussion earlier, but this is all work in progress. I'd like to give you two examples. This is immune response things that are added. This is a new area of investigation, and actually I heard someone say that we should look at the bacterial content of the stool, because this research group thinks that determines the toxicity of the chemoradiation, but why not the effect of radiotherapy? I'm going to give you two examples that show where this could lead to something practical. So this is a group reported by Her et al. From, I believe, Yonsei University in Seoul, Korea. So they, from a group of, like, I believe 15 potential markers. So they did immunohistochemistry. This is a high expression of p53 low, high, low, high, low, high, low. You see that this is sort of a subjective interpretation. And they came out with these four as reasonably predictive. p53 most predictive, and then in descending order. And then they developed a score, but then they realized this is very difficult. It's hard to reproduce. It's not standardized. We're going to do the more modern PCR technique of the same, but they left out VEGF because they found out that it's not so predictive at all. So they used these four, and they put that in a prediction score on a reasonable size of patients. If you have a high p53 expression, your chances of response are low, and in these the chances of response are high. This is a stem cell marker, proliferation index. This is something to do with apoptosis. So simple, they devised a simple cutoff point, and then they grouped it together. And this is PCR, yes or no, and they add the score, 1 to 4. If you have a low score, 0 or 1, there's hardly any chance of complete response. And if you have a high score, there is a high chance of response. There's this middle group that's sort of difficult for them. This adds up to an overall accuracy of 78 to 85%, and they say it's better for low rectal cancer. This is something you could work with. It's not been validated by other centers. I'm sure if other centers do this, it will be a little less accurate. But this might be something you could work with. This is a second example that I've been involved with. It comes from the Maastricht when I was working there. It's a multi-parameter prediction model. They decided we're not going to get there with biomarkers alone, so it was quite easy. Out of an array of 8, CEA, IL-8, and osteopontin was chosen. I had never heard of this thing before. Tumor length, CT and CN as measures of volume. And so this was the first first PET before the start of therapy, max SUV. And if you add everything up, you get a rock curve like this. This is not very very accurate, it would have to be over there, but this is like 75% accuracy. Is that high? It's not very high, but it shows something. And this is validated on a second set too. So you can look at it with nomograms, but I find that very difficult. I'd rather have it in an app or a computer model. You put the data in and it gives you the percentage. Here you have to work your way the probability of a good or a bad tumor response. So what could this lead to for clinical practice? Because nothing of this is ready yet for clinical practice. But let's say you have this type of tumor, very low, it's not big, T2. You could take this patient to surgery and do either an APR or a very low resection. I'm not sure how his function will be after a very low resection. Let's say your prediction model gives you a 70% chance of complete response. I don't think it's going to be much better than that. I mean, you have to add the radiomics data too. You add everything. I could work with this. I could tell the patient, we could give you chemoradiation with this percentage of complete response. If it doesn't work, so your chances of being a loser are only 30%. If the prediction model comes out only 25% chance of a complete response, you might decide otherwise. You might decide to go straight for a very low anterior resection. So I think these are the kinds of prediction models that are going to come your way. So I'd like to conclude that there's not going to be a single reliable predictive factor. It's going to be multi-parametric predictive models using everything we have, and it has to be affordable too. So that's why we're not going to do big microarrays. And I'm quite sure within 10 years it will become useful in decision making. Thank you very much.